Welcome to Part 6 of Pediatric Musculoskeletal Disorders. This video lecture will address osteogenesis imperfecta. This is a very interesting disorder. It is genetic, it occurs in males and females, and it can occur in more than one member of a family. With treatment, these children can live a normal lifespan. If they succumb early, it's usually a complication from pneumonia or severe trauma. Osteogenesis imperfecta affects the bones. They're very brittle and prone to fractures. They develop osteoporosis, and they have multiple deformities. It affects the teeth, the ligaments, the sclera. So when you look at them, their sclera is a bluish hue, and there can be hearing loss. Of all the children I've cared for with OI, I haven't had any who had hearing loss, but they've certainly had all of the other issues. These are x-rays of a 3-week-old who has severe osteogenesis imperfecta. And when you look very closely, you can see femur fractures, tib-fib fractures, pelvic fractures. There's bowing of the legs. This child was born like this. Yes, born like that. How do you change the diaper? Very carefully, because you certainly cannot lift up these legs. You're going to do a lot of sliding type of care. You slide this diaper underneath this child. Here's another picture, and you can see the arm with multiple fractures. The shoulder is fractured, the clavicle, the ribs. And you see all the little beads along this child's ribs. Those are small fractures. And these are some infants with osteogenesis imperfecta. It's really sad, but they're really cute. When you do your assessment, remember they have very fragile bones. When they get their teeth, they're going to be discolored, and they will easily fracture. So we have to be careful what we give them to eat. We don't want to give them any hard candies. Them chewing on that is enough to make them break their teeth. They have altered mobility because of their relaxed ligaments. They can still move. Trust me, when they are angry, they will still try and move these limbs, but in doing so, they end up breaking their bones at the same time. So if there is hearing loss, it's a gradual onset, and by early adulthood, it's going to be gone, and that is because of altered development of those tiny, tiny bones in the ear. So once again, the sclera is blue. They can have respiratory problems because of rib and spine deformities. They can't really take that great of a breath because it hurts to do so. They may bruise easily, and of course they're fatigued. They have to fight pain all the time. In our management, one of our priorities is to protect them from injury. And it's very challenging. This is going to be from infancy through early childhood and for our adolescents. You know they're injury prone anyway just because they're kids. But these kids are excessively injury prone because their bones fracture so easily. We need to teach the parents about safe handling. And the first time that you care for a child like this, the parents are going to teach you how to safely handle their child because they are the expert. So we put these children in a protective positioning, and we use a lot of pillows. When we lift this child up, we're lifting them up on a pillow. You can't just lift them up in your hands. That's enough to break their bones. We want to promote safe activities for this child, what to avoid, and how to practice energy conservation. They still need to move some, but it needs to be very deliberate and safe. As they get older with the treatment, they will fracture less and less and less. It's important that we promote a healthy diet. For weight control reasons, it's very hard to pick up an obese child, and obesity puts tension on a bone and can break it. They also need high calcium and vitamin D. Their growth and the hormonal changes as they grow through adolescence can affect the frequency of their fractures. So the older they get, the less likely they're going to fracture. Now, one thing you need to remember is we do not take blood pressures on these children, because when we inflate that cuff, the pressure from the cuff is enough to create a fracture. The only time we're going to take a blood pressure is if this child comes in extremely ill and we're looking at shock. But once we can put in internal monitors that can monitor the blood pressure, that blood pressure cuff is off. But can you think of other situations where we're going to have to hold the child down to initiate treatment? And one of them is going to be IVs. And so these children are going to get IV medications. They are going to have a central line placed. So the common treatments for our children who have osteogenesis imperfecta include promoting mobility and promoting independence. They need physical therapy and range of motion as tolerated. And these kids, believe it or not, they can swim. So we're going to teach them how to swim. Physical therapy can do that. Casts and splints will be used for their fractures. We also put them in braces to support their legs, ankles, knees, and wrists so that they can actually use them and they can be mobile. Orthopedic surgery is done for rod insertion as needed. They try and get away from doing surgical manipulation as much as possible. Physical therapy and occupational therapy will help with independence type things, particular forks and spoons and knives so that they can cut but not put pressure enough that they're going to fracture, and using canes and walkers for mobility. And then we are going to administer medications to strengthen their bones. There is an osteogenesis imperfecta support group, and we would encourage our parents and children to join that group. Here are some pictures of a variety of rods to stabilize the bones. Other treatments that we have, growth hormone. And some kids might get growth hormone. It's not that they have a problem with their own growth hormone, but they might get it just to enhance their ability to get taller because they've broken their bones so much. They're very short. So this is sort of an experimental approach. They definitely need increased vitamin D intake. We treat them with injectable bisphosphonates. So pamidronate is the most common. We can use reclast also. We get them involved in physical activity, and on the horizon is gene therapy. When you administer pamidronate, I've just copied and pasted in here what the dosage is for these children. And primarily what I want you to know is that these kids are going to come in every 2 months for an infusion. And so we start out with a low dose and then we increase it. And they're going to be in the hospital for 3 days getting this infusion, and then they're going to be discharged, and then you're going to see them 2 months later. So they actually, when you look in other resources for what the dose is, they're going to tell you that the dose is 9 milligrams per kilogram per year. Have you ever heard of such a thing? But that's how they end up dosing the kid, but they split that into the every 2 month version. So they'll receive this all the way through adolescence. And then they continue in adulthood. They get reclassed infusion annually. And this ends the lecture on osteogenesis imperfecta.